essential pediatric radiology films, which will come up in the exam. I've got some messages that you can't hear me. Is that a temporary thing? Can you hear me now? Yeah. Okay. Great. Super. Okay. So Dave Gabura, he's done a session before, and he will go through some pediatric radiology cases. Okay. Quick fire. This is a single MRI scan, which, if you look at it very carefully, you can see that everything that you need is on this study. So we've got a pleural effusion on the right-hand side. We've got pleural lesions. We know it's a pleural lesion because of the obtuse angle that the lesion has with the pleura. And we've got a unilateral breast implant, and we've got what looks like extra soft tissue around the sternum. And so on this one single slice, we can say that this patient has got metastatic breast cancer. That's the kind of thing that you might get in the Viva. Okay, this is a mature patient who has fused epiphyses, and we can see a fairly well-defined lucent lesion straddling the epiphysis and the metaphysis of the tibia. Diagnosis? Germ cell tumor. It's the right acronym, but not the right diagnosis. It's GCT, but it's giant cell tumor. If it was an ABC, you might expect it to be in the metaphysis in somebody who doesn't have a fused skeleton. Okay, so this is a GCT. Oops, ignore that. Oops, I didn't want to show you that. And I've got a malfunction. Oh dear. Anyway, enjoy the view while it lasts. As soon as the ball stops spinning, we'll go on to the next slide. Okay, here we go. So here's another giant cell tumor, which is in the epiphysis of a fused skeleton. Okay, giant cell tumor. Exactly the same pathology, but in a different location. What is the diagnosis here? It's fairly typical. Somebody with acutely swollen feet, but they've been chronically swollen. And we've got juxta-articular erosions. We've got soft tissue swelling. And that soft tissue swelling is of a higher density because of the combination of calcium deposition in uric acid. So this is gout. And if you were to look at the crystals under polarized light, they would be negatively birefringent. Okay, this patient has developed diabetes, and they've got an arthropathy, and they've got a very bronze-looking skin. Yeah, hemochromatosis. So we've got iron deposition in the pancreas and iron deposition in the liver. And so this is hemochromatosis. Don't forget, you may also get a hepatocellular carcinoma secondary to the hemochromatosis, and that's something to look out for. This is the same patient on CT, unenhanced, and you can see that the liver has a higher density than the spleen because of the iron content in the liver. Okay, this patient has fallen on the outstretched hand, and they've now got shoulder pain. Yeah, well done. So there's not really anything wrong with the shoulder. There's a bit of osteoarthritis. There's no fracture, but there is a pulmonary lesion. So don't forget, when you're looking at musculoskeletal films, look at the lungs. When you're looking at the lungs, look at the bones, look under the diaphragm. When you're looking at the abdomen, look at the lungs. You know, it's all basic stuff, but don't forget to do it in the exam. and look for any bone lesions, because then you can upstage the lung cancer if you have spotted it. Okay, the Honda sign in the sacrum. So this is a bone scan. We've got probably a bone fracture here in the rib, but this is the Honda sign of sacral insufficiency. We've also got a probable lesion in the sternum. This is a different patient. So we've got the Honda sign and they've got a sternal fracture. So it's likely to be osteoporosis or osteomalacia. Young male, 25 years of age, and he's got a massive bone lesion. Clinically, he's got an enlarging mass in the vicinity of the right iliac fossa, which is fixed to the underlying bone. Yeah, this is a hemophiliac pseudotumor. I'm sorry about this. I think my screen has just gone. I'll put this back on. Okay, this isn't going to work. So what I'm going to do is, let's try that again. Just bear with me, guys. Okay, hang on 1 second. Are you able to see the screen now? Yeah, you can. Sorry about that. I had a slight technical problem. My monitor just went offline. So what's the diagnosis here? Right lower lobe collapse. Excellent. Okay. Now, right lower lobe collapse can be quite difficult to pick up sometimes, especially if the interface of the collapsed right lower lobe is superimposed over the right heart border. So one of the ways of knowing that this is a right lower lobe collapse is to see that there is an absence of the interlobar artery, which has been pulled down and inwards. So normally the interlobar artery is seen because you've got aerated lung around it. So there's the interlobar artery. Okay. And when we get a right lower lobe collapse, the solid lung around that interlobar artery obscures the artery. So if we go back to the chest x-ray, you can see that the interlobar artery is, well, it's just not present. And that's because it's been pulled down and into the right lower lobe collapse. The other subtle signs are that you've got volume loss in that right hemithorax. So the right hemidiaphragm is slightly higher. And clearly, when you look at the CT scan, we've got the golden S sign, which indicates that there is a tumor which is causing that right lower lobe collapse. Note also the patient's got a small pericardial effusion. And so whatever's going on centrally may also be involving the pericardium. So the lack of the interlobar artery is a really, really strong clue that you've got a right lower lobe collapse. And of course, you've got the other radiological signs. Now, while we're on the subject, I'm going to show you another example of a right lower lobe collapse. Again, we've got the right hilum, which has been pulled down and inwards. We can't see the interlobar artery. And there's the interface of the right lower lobe, which is superimposed to some extent over the right heart border. And the CT scan shows that we've got a right lower lobe collapse. Now, again, we've got the golden S sign, and that is almost always a bad sign. It's a sign of malignancy. And this patient has also got emphysema. So when patients present for the very first time with a lobar collapse, and they are over the age of 45, often with a smoking history, it's got to be an endobronchial tumour until proved otherwise. And you need to tell the examiner that you're going to go through the usual steps of suggesting a staging CT of the bronchus and inclusion in the MDT with further investigations, which may involve a PET scan and a lung biopsy, and possibly something endoscopically. Here's another right lower lobe collapse, and we can see that the interlobar artery should be thicker than this one. This is just a branch artery of the middle lobe. And so the interlobar artery, because we can't see it, it's incorporated in this solid right lower lobe collapse. This patient was fairly well for an ITU patient. There's the ET tube. They have a right internal jugular line put in. And as soon as the right internal jugular line gets put in, the patient goes off, saturations go off, the pressures required to ventilate the patient go up and up. And so this is a tension pneumothorax. And the reason why it's a tension pneumothorax is, here is the left hemidiaphragm, just there. And the right hemidiaphragm is so far depressed and everted that it is now way below. So the depression and eversion of the diaphragm is a radiological sign of tension. Now clearly, this should be recognized clinically, but when it does present itself radiologically, it's the depression and eversion of the diaphragm that suggests that we've got a tension pneumothorax. And that can be treated very promptly with a green needle or a small bore cannula in the second intercostal space midclavicular line. And you should get this whooshing noise coming out. Now, the reason I say that is that I've actually heard that whooshing noise when I've put the needle in myself. So it does happen. I've had a couple of tension pneumothorax cases in trauma and also when I was doing a lung biopsy. So it does happen. Okay, we've got a young female. She's a chronic attender at A&E and also clinic. Can you see the expanded ribs? Yes. Can you see the posterior mediastinal mass lesions? Yes. Expanded clavicle. Let's have a look at the MRI scan. The lungs are actually okay in this patient. The CP angles are nice and sharp, but the patient has got on T1 weighted imaging, the normal high signal of the bone marrow has been replaced by red marrow. And so we've got a loss of signal on T1. The discs have a higher signal than the bone marrow. And we've got bone marrow growing outside of the bone marrow. So this is called extramedullary hematopoiesis. This is intramedullary hematopoiesis. This is extramedullary hematopoiesis. And don't forget, in thalassemia, you get the defective hemoglobin. You've got a lot of hemoglobin which doesn't oxygenate the tissues very well. And so what happens is the body produces more of this defective hemoglobin. It's a kind of hemoglobin F, or the hemoglobin that we had when we were fetuses. And it doesn't oxygenate tissues very well. So the factory, if you like, that produces all the red blood cells just carries on producing the red blood cells. And when the bones are expanded and they can't expand anymore, the erythropoietic tissue occurs in potential spaces outside the skeleton, such as the paravertebral regions. Don't forget, the liver can become a site of defective erythropoiesis, and then this has a low signal. And the spleen has been removed quite simply because the patient complains of pain over the spleen. And so that's why these patients tend to get splenectomies. Thalassemia, more of it. We've got extramedullary hematopoiesis in the maxillary sinuses. So you've lost the air in the maxillary sinuses. And you've got the inner table and the outer table, which are further apart due to diploic expansion. And note that the inner table looks okay, but the outer table is thinned, and that's because the expansile force within the diploic space causes tension of the outer table, but compression of the inner table just by the convexity and concavity of those tables. And so we get thinning of the outer table. You're probably used to seeing this image here where you get the hair and end appearance. And that's very nicely seen on the frontal projection, again with the filling in of the maxillary sinuses. Don't forget that these children clinically will have protruding maxillary teeth. And that's a typical appearance of somebody who's got thalassemia. Thalassemia, when translated from the Greek, literally means anemia by the sea. Okay, this is an 82-year-old lady who came in with bloody diarrhea and abdominal pain. And what you can see here is dilated bowel. The haustral folds are non-existent. And we've got thumbprinting. We've got thickening of the bowel wall because we've got two adjacent bowel lumina and walls close together. And so this is about 1.5 centimeters thick. And then we've got pseudopolyposis. And pseudopolyposis looks like a polyp, but actually it's not due to a polyp. It's due to something that looks like a polyp, and hence the name pseudopolyposis. This is actually a patient who's got ulcerative colitis and pseudopolyposis. Now, why do you get pseudopolyposis? Well, when the mucosa sloughs off, you get edema of the remaining mucosa. And the edema of the remaining mucosa stands proud of the submucosa, and you get aerated. It's a bit like the silhouette sign where you've got a lung nodule and aerated lung, but you've got what looks like heaped up edematous mucosa, and then you've got gas in the lumen of the bowel. And that's why it looks like a polyp, but it's actually a pseudopolyp. Now, you may not have seen this before. This is a small bowel meal in somebody who's got acute on chronic abdominal pain. Now, it's a rather unusual investigation for acute abdominal pain. I think nowadays, most patients will have a CT scan. So this is probably a little bit historical. It does look a bit like scleroderma, but can I just allow you to cast your eye over the liver? What can you see here? You can see branching structures which contain the barium. And although this does look like scleroderma, the stacked coins appearance, we've actually got a filling defect in the distal jejunum. Okay, the proximal ileum or the distal jejunum, that filling defect. And at 1.5 hours, there was no change from the appearances at half an hour. So there's a fixed mechanical obstruction here, whereas scleroderma is a functional obstruction. And we've got barium in the biliary tree. Now, if you replace the barium with gas, take the barium out of this X-ray, you'll have gaseous distension of small bowel, you'll have an ectopic gallstone, and you'll have gas in the biliary tree. So you've got gallstone ileus. So this is gallstone ileus like you've never seen before. It's on a small bowel meal. Okay. So in the exam, the examiners will expect you to pick up things that are common, things that you can see in the books, etc., etc. But they want you to also work things out by thinking about them. So even though you've never seen it before, you are expected to kind of work it out. And you can do that if you just keep your wits about you and remember why this patient has presented clinically, and then see if you can work it all out. This patient has got acroosteolysis, intracortical tunneling or subperiosteal resorption on the radial aspect of the phalanges. They've also got TFC calcification, chondrocalcinosis. They may have a brown tumor here. They may have a brown tumor there. I'm not sure whether they do or they don't, but logically, and using Occam's razor, that's probably going to be a brown tumor given the fact that this is hyperparathyroidism. And the only cause of intracortical tunneling along the radial aspect of the phalanges is secondary hyperparathyroidism. And it's secondary almost always in the UK to renal disease. Okay, how do you tell the difference between a femoral hernia and an inguinal hernia on CT? And is it important, or is it just an academic exercise? Well, it is important because an inguinal hernia is less likely to strangulate than a femoral hernia. Femoral hernias are seen in women 7 times more common than men. And the thing about an inguinal hernia is it's almost always medial to the pubic tubercle, which I'm just pointing out there. The femoral hernia, on the other hand, is almost always lateral to the pubic tubercle. Now, because the femoral hernia, the peritoneum, the omentum, plus or minus bowel, is going into the femoral canal. The femoral canal is a small anatomical area that's normally got the vein, artery, and nerve in. So if you've got a small canal and you put something else into it, which of those 3 structures that go through the canal is likely to be squashed? Yeah, it's the vein, isn't it? So you've got the femoral vein, which is going to be squashed. And I'm going to demonstrate that on the next couple of slides. So as you go a bit lower down, you can see that the femoral vein is a bit squashed compared to the other patient. But let's compare it in the same patient. And can you see how squashed that femoral vein is compared to the femoral vein on the left side? And that's what you want to do. You want to compare it with the same patient, but on the other side. And that's a femoral hernia. And that really needs flagging to the surgeon to try and get a prompt elective treatment for that. Whereas this is the inguinal hernia, which has no effect whatsoever on the femoral vein. Somebody's asked me how to differentiate between a direct and indirect inguinal hernia. I'm afraid I cannot tell you because I don't know the answer to that. If anyone does, please let us know. But I'm not aware that you can radiologically. But please tell me if I'm mistaken. Okay, so that's the pubic tubercle, and the features I've just described are nicely shown. Okay, this is a great case. Patient has had neck surgery. They've got a lucent lesion in the humeral head. They've got an expansile rib. They've got small kidneys. That's an expansile rib also. They've got expansile bone lesions, almost like soap bubble lesions in the iliac blades, and also in the sacrum. And let me just go back one slide. What have they got in the right iliac fossa? They've got a transplant kidney. So they've got renal osteodystrophy with brown tumours. And what surgery have they had in the neck? They've had a parathyroidectomy. Don't forget, parathyroidism, hyperparathyroidism, can be primary, secondary, or tertiary. Primary is an adenoma. Secondary, which is more common, is secondary to renal failure. And when you get autonomous, unopposed secretion of the parathyroid glands, as you do in chronic renal failure and secondary hyperparathyroidism, you then get into a state where you've got tertiary hyperparathyroidism. And that kind of acts like a primary parathyroid adenoma. And one of the treatments is to remove the parathyroid gland. And that's what's happened here. So it's quite a nice case illustrating the radiological and musculoskeletal features of hyperparathyroidism. Okay, this patient presents with abdominal pain. Just some selected CT scans of the abdomen in this patient. Yeah, interception of the colon. Okay, so it looks like a colocolic interception. And interception in children could be due to Peyer's-Patch's hypertrophy or hyperplasia. And in adults, it's almost always caused by a space-occupying lesion. And you can see that there is a lipoma of the large bowel causing the interception. Now, if it's not a lipoma, it's almost always going to be a carcinoma, and rarely it can be a lymphoma. So this is interception of the colon due to a colonic lipoma. Diagnosis. Left lower lobe collapse. Yeah, well done. So we've lost the left hilum. It's gone down and been tucked in. We've got hyperexpansion of an already emphysematous lung compared to the other side. It's a bit subtle, really, but there's the sail shape of the left lower lobe collapse behind the heart. Where is that catheter? There are two catheters and they're both heading off down the left-hand side. Yeah, it's a left-sided SVC. It goes adjacent to the aorta, behind the left atrial appendage, behind the left atrium, and then into the coronary sinus, and then into the right atrium. And it's inconceivable that the patient has got a right-sided SVC, because why would two of those catheters preferentially go to the left when they would normally go to the right? So this is a solitary left SVC. And this patient is mildly breathless and they have dysphagia. What's the diagnosis here? Yeah, brilliant. Scleroderma, or to be exact, it's the Crest syndrome. So they've got the calcinosis, the Raynaud's phenomenon, E for esophageal, it's the American spelling. They get esophageal dilatation. And in this particular patient, they've got absolutely characteristic features of non-specific interstitial pneumonitis. You've got peripheral spurring, you've got traction bronchiectasis, you've got architectural distortion. But the key thing here that distinguishes it from UIP is that there is no evidence of honeycombing. So you don't want to tell the examiner that this is honeycomb lung, because it isn't. And this is traction bronchiectasis, and you've got this peripheral spurring, which is characteristic. And don't forget that it's almost certainly the case that when you've got NSIP, you've got obviously a connective tissue disease is probably going to be associated with this. Yeah. So NSIP, non-specific interstitial pneumonitis, that's fine, but it's probably going to be related to connective tissue disease associated fibrosis. Okay, last one from me before I hand over to Dave. What's going on in this patient here? Weight loss and cough. Yeah, Luftschüssel, sickle, left upper lobe collapse. Yeah, anything else? So we've got volume loss in the left hemithorax. We've got this increased density in the left hemithorax compared to the right. We've got probable mass lesion. Okay, you can see some hilar vessels, but a lot of them are obscured by what looks like a mass lesion. And there's a little bit of tenting of the left hemidiaphragm at the insertion of the inferior pulmonary ligament, and that's one of the hallmarks of volume loss. But can anyone see that this rib is destroyed? And this is the incomplete border sign. So I can see that it's nice and sharp here, but it fades superolaterally. And that's because the destroyed rib is associated with a soft tissue mass, which is sharp medially and fades laterally. When we do the lateral film, all we can see is that the spine is supposed to get blacker as you go from top to bottom. And it kind of does really, but just where you've got this rib mass lesion, it becomes opaque and then it becomes less dense again. And the reason why it looks sharp medially is because the X-ray beam is tangential to the interface between the mass lesion and the lung medially, but its interface is probably at 45 degrees laterally, and that's why it's blurred. And that's why it's so important to recognize whether it's a pulmonary lesion or an extrapulmonary lesion. It's all very well spotting the abnormality, but you've then got to nail it in terms of its anatomical appearance. Okay, so very important. And this patient has clearly got a left upper lobe collapse. There's a very subtle golden S sign, the mass lesion causing the left upper lobe collapse. And in fact, that patient did have a rib metastasis. If you were going to biopsy anything, it's probably better to biopsy that, because most radiologists would agree that that's going to cause minimal patient suffering, really. They probably don't even need a bronchoscope if that reveals the diagnosis, because it upstages the patient and is relatively non-invasive compared to endobronchial biopsies, etc., etc. So thank you very much for your time. I'm going to hand over to Dave, who is a co-host. I'm going to stop sharing, and thank you very much. I will speak to you at the end of Dave's talk at about 7:30 or whenever Dave finishes. So thanks, Dave.
Thanks very much, John. Right, let me just share my screen. Hello, everyone. My name is Dave Garborough. I'm a consultant radiologist in Liverpool at Alder Children's Hospital. Hopefully you can see my screen. And I'm going to show you in a similar style to John, lots of FRCR style pediatric cases. And I always start with this one because it's one of the most important pathologies that you cannot miss in children. So this is two different children with the same pathology. They're both 2 days old, and they have bilious vomiting. And yes, so midgut volvulus is the right answer. So what you must make sure of always, this child has been administered water-soluble contrast via the NG tube into their stomach. You can see contrast leaves the stomach via the pylorus, enters D1, D2 should course inferiorly, D3 should course back over the midline, and D4 should end up in the DJ flexure to the left of the midline in the transpyloric plane. And you can see that in both of these patients, that doesn't happen on either occasion. So here we have a corkscrew sign, so twisted bowel due to a twisted mesentery that does not cross the midline. And on this side, although there's no twisting, the DJ flexure is clearly in the midline, just to the right of the midline, and then the proximal jejunum courses down to the right lower quadrant. So this is a midgut volvulus and is a surgical emergency. So please remember the position of your DJ flexure should always be here. So this is malrotation or midgut volvulus. You can call whatever you like. Malrotation doesn't necessarily need to have volvulus, but if you see this appearance in a child, even if it is not volved, it will still go for surgical fixation. This is just a reminder of what a normal DJ flexure position is. So in the AP view, this is where you should find it, to the left of the midline in the transpyloric plane. And then this is a lateral view. This is the pylorus here. Contrast passes through D1, which is retroperitoneal, so it heads back towards the spine. D2 back towards the spine, D3 upwards, and then D4 back superiorly in a U shape. And this is the DJ flexure. So this is normal. Okay. This is a 1-day-old on the neonatal unit. So I can see people saying already, you've very well spotted that at the top of the image, we've got a coiled NG tube that cannot be passed down the esophagus. That's because we've got an esophageal atresia. So you can see there's lucency here in the proximal esophageal pouch, and it's dilated, which suggests we've got an atresia or a pouch here that the NG tube can't pass beyond. And I can see some people saying with distal fistula, yes, exactly. That's very well spotted. So how do we know that this is with a tracheoesophageal fistula also? Because we've got gas in the stomach. So there is likely to be a connection between your distal pouch and the trachea. Now that is often in the region of the carina. So you probably have a little pouch here, then your distal esophagus courses normally towards the stomach, and that's why we've got gas there. Now let me get rid of my annotations so you can see something else. I can see someone has already said butterfly vertebra, so we've got an associated vertebral anomaly at T12, 11, 10, 9. So here is a butterfly vertebra. So we've got esophageal atresia, tracheoesophageal fistula, and a vertebral anomaly. The very astute amongst you will have realized this is a vactral anomaly. Very well done. So remember, vactral anomalies include vertebral anomalies, anorectal malformations, cardiac anomalies, tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb anomalies. So to complete this case, you would suggest that the child needs a renal ultrasound, a spinal ultrasound, and an echocardiogram. Very well done. This is a 12-year-old child who came to A&E after falling in the playground. So yes, classic FRCR case. This is rickets. So what is rickets? Rickets is a vitamin D deficiency, usually in this country dietary, is the issue, but could also be due to lack of sunlight, depending where in the world you live. And these are classical appearances of rickets. Now, this is a slightly older child, which makes it look a little bit strange because we have a very wide physis, but we still have the classic triad of cupping, splaying, and fraying of the metaphyses of the long bones. So the wrist is often where you see this, also the knee. And remember why this happens is because in rickets, it's the failure of the cartilage to mineralize at the physis and undergo resorption. So you get disordered proliferation of chondrocytes in the hypertrophic zone here. So the chondrocytes do not mineralize, are not allowed to cross the physis, and they stack up at the metaphysis, which is why you get this widened, splayed, and frayed appearance. And ultimately, that results in poorly mineralized bones. Okay, this is a 9-year-old who was tackled during a rugby game. Lots of people getting this one. Yes, simple bone cyst or unicameral bone cyst with a pathological fracture. What makes you say that this is definitely a simple bone cyst? Fallen fragment. Yeah, exactly. So in terms of the exam, could this be anything else? No is the answer. There's sometimes in medicine, never say never, but certainly in terms of the exam, this cannot possibly be anything else. It's pathognomonic. Yeah, exactly. So we've got a fallen fragment sign here. So a fragment of the pathological fracture lying dependently within the cystic change. And we can see here that we've got some thinning of the cortex. It's in a classical position in the diaphysis of a long bone, often the humerus. And we have a narrow zone of transition between the normal medulla of the bone and the expanded lucency of the unicameral bone cyst. So this is a simple bone cyst with pathological fracture. I can see some people saying ABC, and I can see some people saying Langerhans cell histiocytosis. So Langerhans cell histiocytosis may look like this, but we've got pathological fracture with the fallen fragment. So that's what would make me think we're more towards a unicameral bone cyst. And it's not a typical position of an aneurysmal bone cyst. That would usually be more metaphyseal. This is diaphyseal, which makes it more likely to be a unicameral bone cyst. Okay, this is I can see someone asking next step with that one as well. The next step for that, they usually don't fix these actually. The surgeons will normally manage that conservatively. This is a neonate on the neonatal unit with vomiting and has become generally unwell. So necrotizing enterocolitis, I can see some people saying, yeah. So we've got I agree, perhaps some pneumatosis in the right flank here, slightly mottled, bubbly appearance of what is probably the ascending colon. And one person has said the really critical finding here, which is presence of the falciform ligament or visualization of the falciform ligament. Have a look in this area here. Now, this is a very subtle sign, and I hope you can see it well on this projection, but there is free gas here, correct? So this is pneumoperitoneum in a neonate, which, as you said, is most likely to be due to the to necrotizing enterocolitis. Could it be typhlitis? I think it's unlikely to be typhlitis unless you have a child that's on chemotherapy and has known risk factors to have typhlitis. In a neonate, pneumatosis is much more likely to represent necrotizing enterocolitis. Let me go to the next slide and zoom that up for you. So you can see where my red marker is here. This is the outline of the falciform ligament, which you should never be able to see on a plain film radiograph. And there is a little bit too much lucency over the midline and over the liver. So this is a subtle sign of pneumoperitoneum. This is a different child, but perhaps if you hadn't spotted the abnormality, this is what it may well look like on the next radiograph. So yes, this is gross pneumoperitoneum with a football sign. So here we have huge rounded lucency over the whole abdomen. We've got Wriggler's sign where we can see lucency on both sides of the bowel wall. We have the falciform ligament here again that you can see, and large domed area of lucency beneath the liver, or a cupola sign, which I'm sure you've heard Dr. Curtis talk about before, because it looks like the dome of an Italian church. Or continuous diaphragm sign, yeah, absolutely. So, what are the biggest risk factors for necrotizing enterocolitis in neonates? Prematurity, yes. So that is the biggest risk factor of all. And I can see somebody else has said cardiac anomalies. That is number 2, yes. And as you can probably appreciate, this child has got a stent in their heart. So this might be a PDA stent, might be a right ventricular outflow stent. Either way, in the context of the exam, I don't think it matters. What you should hopefully see here is they've had cardiac surgery. You'll notice the cardiac apex is also elevated and the heart looks rather boot-shaped. So I can see some people again saying tetralogy of Fallot. Yes, exactly. So this child has tetralogy of Fallot, and post-operatively they've got necrotizing enterocolitis and a perforation. You can't see it amazingly well, but let me clear all my ink again. There is also a hemivertebra here. So this child also has Bactal as well. So plenty to find on this film, and is a good exam case. One word of warning while I remember. You'll notice that the humeral heads, or the proximal humeral epiphyses, are absent on this radiograph. This does not mean the child is premature. It can be a sign of prematurity, but it can be up to 6 or 7 weeks post-term before these ossify. So be careful in an exam situation of saying that children without ossified humeral heads are premature, because it's not quite true, but it might help you decide whether prematurity is a risk factor for them or not. The femoral epiphyses come later. So off the top of my head, I think it might be 6, 7, or even 8 months before you might see proximal femoral epiphyses, but the humeral ones should be there within a few weeks post-birth, or post-term, I should say. What's a sure sign of preterm? There isn't one really. Let me think. I can't think of anything definitely skeletal that I would look at to be sure that a child is preterm. I think humeral heads are not a bad sign, but please don't be definitive about it in the exam. This is the same child. Let me show you this video. This is the portal vein. This is the porta. This is the portal vein here. If I draw your attention to that, you should be able to see bubbles of portal venous gas moving through the portal vein. So although we couldn't see any branching portal venous gas on the plain film, let me just see if I can play that for you again. We can see when we do an ultrasound of this child that there is definite small bubbles of portal venous gas moving through the main portal vein. And this area here is all complex free fluid at the porta. Okay, what do you do if you're not sure if you've got free gas on a supine or AP radiograph? You can do a lateral decubitus radiograph, yes. So we always prefer the right side to be up. That's because we can use the liver edge to outline free gas. So you can see that all of this gas here is free, and we've got a good Wriggler's sign here as well. So remember, if you are not sure, this is what you can recommend. If the child is not well enough to lay on their side for 5 or 10 minutes, you need to make sure that the child is on their side for 5 or 10 minutes to give the gas time to rise. You could leave them on their back and do a lateral shoot through with the anterior abdomen in the air. Okay, this is a 3-year-old with hip pain. Now be careful with your answer here. So I can see some people have said osteomyelitis. I can see some people saying Ewing's. But the people with the best answer are people saying aggressive lesion. Yes, very well done. So we've got right proximal femur here. You can see there are lots of nasty signs on this radiograph. First of all, we've got a patchy, mixed, sclerotic and lucent moth-eaten appearance of the femoral neck extending down into the femoral diaphysis. We have thick, lamellated areas of periosteal reaction extending from the metaphysis down the physis. We've got some cortical disruption over here where it looks a little bit moth-eaten. So yes, there are signs here of aggressive bone lesions. Could this be osteomyelitis? Yes. If I told you this child had a CRP of 400 and perhaps they'd had orthopedic procedure or they'd recently had a large cut on their thigh, yes, this could be osteomyelitis. Or this could be a primary bone malignancy. Could also be a metastatic deposit. Where would the most likely metastatic deposit be from in a child of 2 or 3 years old? Yeah, neuroblastoma would be the big one. Wilms. Now, be careful with Wilms. Wilms tumors don't often metastasize to bone. They preferentially go to the lungs. So if you see liver or bone metastases in a large renal tumor, think about something more like a clear cell sarcoma of the kidney, or maybe a malignant rhabdoid tumor of the kidney. Yes, lymphoma could also look like this. Quite unusual in a child of 3. And I'm glad nobody has said osteosarcoma either, because that would be very unusual for a child of 3, much older children towards the teenage population. So the best answer here is an aggressive bone lesion, and I think osteomyelitis and Ewing sarcoma are the 2 best options, or metastasis from a neuroblastoma. This is a 4-year-old or 5-year-old who fell in the playground last month and is now presented to A&E with a swollen finger. Dr. Curtis showed you a case before where he said it's probably something you've never seen before, but how do you deal with it and what do you do with it? And this is one of those cases. So lots of answers here. Langerhans cell histiocytosis, vanishing bone, post-traumatic osteolysis. Yes, all not bad answers. Langerhans cell histiocytosis would be very unusual to destroy a whole bone. Vanishing bone disease. Yes, that's not a bad answer, but we'll come to that. What if I told you the finger was red, hot, and swollen, and the patient had white cell count of 40? So osteomyelitis. Yes. So this actually did turn out to be MRSA osteomyelitis that has destroyed the entire middle phalanx of the 5th digit of the right hand. And when they went to theatre, this phalanx had all been completely replaced with pus, and Staphylococcus aureus was the organism in the end. Very unusual to progress so quickly. Are the adjacent bones pristine? Well, let me get rid of the ink. Can you see how the surface of the distal portion of the proximal phalanx here is also a little bit ragged and a little bit moth-eaten? So it started to encroach on the proximal phalanx as well. If you compare the proximal phalanx tip here with the 4th finger, You can see how it's ragged and moth-eaten. And remember, there are not many processes that cross the joint line. Even malignancy sometimes is unlikely to cross a joint line, but infection will certainly do that. So this was infection. Vanishing bone disease, yes, is the other option here, or Gorham-Stout disease. So this is incredibly rare, and it is when you get a lymphatic malformation within a bone that overtakes the bone and destroys it. So that would be a differential here, but you wouldn't expect such a dactylitis with that, I don't think. Such a red, hot, swollen finger with raised inflammatory markers. Could this be a congenital malformation of the finger? No. Yes, it's a leading question. It's very unlikely to be a congenital malformation. Why? Because if it was never there, then these two bones should articulate together. You're unlikely to have a middle phalanx shaped hole, just the right size for a 4-year-old, if it had never been there. So yes, but it's something you might be tempted to say quickly in an exam. But yes, very well done. Okay. This is a neonate on the special care baby unit. Meconium peritonitis, yes. So this is a meconium peritonitis. So you can see here there are lots of areas of linear sheet, almost sheet-like or rounded areas of calcification across the whole peritoneum, also outlining the surface of the liver. So this may be something that you see incidentally on a plain film, or it might present in unwell children with abdominal signs. This is usually due to a meconium or an intestinal perforation with a chemical meconium peritonitis in utero that often seals itself. So by delivery, there's no longer perforation, but you've got the sequelae of a previous chemical peritonitis in the abdomen, and these can persist for a long period of time. So yes, in utero perforation. And I think you're right, it does resolve with age. I think it does resolve with age. So over a period of months and years, these calcifications will resolve. Is it a consequence of NEC? No. So this tends to be, so if you imagine when a child has necrotized enterocolitis post-delivery, meconium should have passed. So if you get perforation at that point, you aren't going to get a chemical peritonitis with meconium like you do here. So this is an in utero perforation that spontaneously seals, usually prior to delivery, and this is what you're left with. No rectal gas. Yes, there is not a lot of rectal gas here. You don't have to see rectal gas on every neonatal film, but you're right, it is a reassuring sign that you don't have any perforation. Sorry, obstruction. Remember with neonatal gas patterns, you should have gas within the stomach at birth. You should have gas within most of the small bowel by about 12 hours. And you should have gas all the way around the colon and the rectum by 24 hours. So don't make any assumptions on bowel obstruction or gas pattern before the age of 24 hours because you may not have gas across the whole of the GI tract. Okay, this is a 3-month-old with projectile vomiting. Yep, hypertrophic pyloric stenosis. So this is a longitudinal view of the pylorus, and you can see here, so this is the pyloric wall here, and should not be any more than 3.5 millimeters in thickness. Now that's very difficult to measure on 3.5 millimeters on an ultrasound is very difficult to measure. What I would say from a practical point of view is that if you can measure it 3, it is normal. And if it measures 4, it is abnormal. Sometimes images are very borderline, in which case what you should do is repeat the ultrasound after 48 or 72 hours. Usually once it begins to hypertrophy, it hypertrophies very quickly, and you will see a change in as little as 48 or 72 hours. Remember, your canal length is also important. The canal length shouldn't really be any longer than 15 millimeters. Certainly 16, 17, 18 millimeters is too long, and it's elongated because it's hypertrophied. In the transverse view, your widest diameter of the pylorus shouldn't be any more than about 13 millimeters or 14 millimeters. There's no general consensus on these measurements. Different literature will tell you different things. So I think in the exam, they'd be likely to show you one like this that is very much obviously thickened with pyloric walls of 4 or 5 millimeters and a canal length of 19 or 20 millimeters. Remember, this presents with non-bilious vomiting. The child will have a metabolic alkalosis, and they're often very, very keen to feed. Now, this is the opposite of a malrotation volvulus, which will present with a metabolic acidosis. The child's lactate will be raised, possibly because the bowel is ischemic and dying. They will be lethargic and not willing to feed, and the vomiting is bilious. So this is how you can differentiate. And remember, clinically, the ages of presentation are different. About 90% of children with malrotation will present in the first year of life, and about 3/4 of those within the first week, whereas a pyloric stenosis is likely to present usually at the very earliest 3 weeks of age, up to about 12 weeks. Okay, let's do one or two more quick ones because I'm running out of time. This one is a classic FRCR film. Yep, double bubble sign of duodenal atresia. So we've got two bubbles. We've got a gastric bubble here over on the left side of the abdomen. We've got a dilated duodenal bulb and absolutely no distal bowel gas whatsoever. So this is pathognomonic or almost pathognomonic of duodenal atresia, and no further imaging is required here. This can go straight to theatre. Or at least the surgeons will normally be willing to take this patient straight to theatre. Okay, this is a neonate. Mass, yes. So remember, even if this film was in the first 12 hours of life and we've only got gas in the small bowel, remember the small bowel should generally be over here somewhere on the left side of the abdomen. All of the small bowel in this case has been pushed over to the right-hand side by this very large intra-abdominal mass. I don't have the follow-up cross-sectional imaging for this, but I think this was a congenital mesoblastic nephroma. So clue is in the name. Remember, any large intra-abdominal mass in a neonate could be neuroblastoma potentially, but if it's arising from the kidney, think CMN, congenital mesoblastic nephroma, which are benign tumors, or generally speaking, benign. Right, have I got anything quick? Let's show this. I'll tell you about this one. This is a cystic nephroma in an 11-month-old. You can tell this is not a Wilms tumor because it has no solid component. This is a T2 axial MRI. You can see it's almost completely cystic, only with these intervening septi. No solid component whatsoever. So remember, Wilms tumors often affect children at the ages of 2, 3, or 4. If they're less than 2, think about other things. And this is a cystic nephroma. Could it be hydatid? The unusual place to get it, the liver, is where you would normally be looking for hydatid cysts, and they would need some kind of exposure to that as well. Let's make this the last one because I think I've run out of time. This is a less than 1-year-old. Yeah, proximal focal femoral deficiency or deficient upper femur. Yes, so this is a congenital partial absence of the proximal end of the femur, and it usually results in shortening of the entire lower limb. So there's usually associated acetabular abnormalities and articulation abnormalities between the femoral head and the acetabulum. The problem is you don't know how much of the femur here is cartilaginous. So the gold standard here is to do an MRI to find out. And does anyone know what this is normally associated with or can be associated with elsewhere in the leg? Last slide. Fibular hemimelia. Yes. So if you image the whole limb, you'll usually see that there is some kind of deficiency with the fibula, either partially, in this case, or the whole fibula may be missing. And right, I've done at least half an hour, so you must all be wanting to go. But thank you so much for listening, and I hope you found it useful.
Dave, thank you very much indeed. That was absolutely fantastic.